Bismillah ar-Rahman ar-Rahim. Muneeb's questions about lithium and then about pros and cons of sustained and instant release formulation or formation. So, number one is, what is the ideal starting dose of lithium? The ideal starting dose of lithium is 400 milligrams. However, in elderly population, because of increased bioavailability and more kind of body fat than water, so disturbed fat to water ratio, and in patients who are sensitive to the side effects of lithium, it is advisable that you start with 200 milligrams nocte, like 200 milligrams HS at night. So that's the answer. Usually 400 milligrams, in certain people 200 milligrams. Number two, which dosage regime is better, OD or BD? For most of the medications, it's the OD regime. As Professor Nasir also said, that why do we give risperidone and other things as BD? Risperidone can be given as OD. Yeah, quetiapine is BD. It depends on the half-life. If it is 12 to 18 hours, then BD dose is better than OD. If it is more than 24 hours, then OD is better. So I would go with OD regime for this, for lithium, and it is always given OD in the West. So it is nocte at night time. Could be 200 milligrams nocte, 400 milligrams nocte, 600 milligrams, 800 milligrams, up to 1400 milligrams nocte if required. But at that high dose, you need to check the level more frequently and monitor the kidney function as well. What strategies can we implement to minimize its dreadful side effect of renal failure? Excellent question. First of all, we need to measure the renal function every 3 to 4 months, maximum 6 months. Then the most important thing in measuring the renal function is the estimated GFR, eGFR, and so if in the Western laboratories it is done quite reliably. In Shaukat Khanam in Lahore, it is done. It's good and done reliably. So the urea, creatinine, and estimated GFR, eGFR. These three things you need to monitor from time to time. If GFR starts going below 90, start thinking. If it goes below 80 milliliter per minute, start thinking even more strongly. Depends on the patient's age. If it is elderly, it's okay. Now, if it goes below 70, start thinking even more strongly. If it is elderly, that may be okay. But once it goes, once it goes below 70 in a younger population, I would personally think of taking him off lithium. And when it goes below 60, I would definitely take him off lithium Otherwise, there is a probability, there is a possibility that they may end up having chronic renal failure or chronic kidney disease. So below 60, definitely take off lithium, and it will be wise if it goes below 70 to take off lithium as a precaution if alternatives are available. What I do normally in my practice is that I tell the patients that lithium is only for maximum 10 to 15 years, and then I would think of something else. Let's say if the woman is in a childbearing age, so you're giving valproate, and then she comes out of the so you can't give sodium valproate. You ideally you give quetiapine, or then lithium may be second choice. It is safer as compared to sodium valproate, but it's not entirely safe. So in those cases, after 10 to 15 years, I would take them off lithium, and when the woman has past the childbearing age, I will consider sodium valproate in her at that stage. So that is the answer. That and the other thing is, you said that what are the strategies we can implement to minimize its dreadful side effect of renal failure. First thing is, drink plenty of water. Drink plenty of water. Not to the extent that you're drowning into the water and causing hyponatremia, but I think it's more water, better it is, and especially in the climate of Pakistan and India, where it is hot climate, and and in the climate of Arabia, I mean, over drinking won't cause any harm. So yeah, drink plenty of water, and especially when you are going to holidays, drink plenty of water. Because what the Westerners do, they go on to the holidays in the eastern areas, and even if they go in winter, it will be relatively warmer in United Arab Emirates, etc., in December or January. So there is a chance, patients can get lithium toxicity. So the patient who is going on holidays and is on lithium, take good precautions and drink plenty of water. Secondly, now some patients, what they do is, when they are manic, they stop looking after themselves, and they stop their lithium. And if they stop their lithium, that's fine. But if they are taking their lithium, but if their water intake, they are taking their lithium and their water intake is reduced due to their mania, that's alarming. Because because of the dehydration, they can go into acute renal failure or acute kidney injury. And if they are taking lithium on top of that, in that state, then they can develop lithium toxicity. So if the family must be knowing that if the patient is drinking enough water or not, and if the patient is in that state that they are not drinking enough water, then it is better to stop lithium or hold lithium for the time being until the clinician restarts it, because otherwise there are risks of acute kidney injury and lithium toxicity and dehydration. So that is one reason, that's one strategy. And And then the second thing is that what strategies we can, what strategies we can implement to minimize its dreadful side effects of renal failure. The other thing is drug interactions. So do not give lithium with NSAIDs, ibuprofen, naproxen, because the side effect, the drug interaction will put them into the lithium toxicity. So it's not advisable. And then the other thing is ACE inhibitors and ARBs. So ARBs, angiotensin receptor blockers. So if should not ideally give these two medications along with lithium. However, some literature says that if a person is on I think it is about NSAIDs, that if they are on regular NSAIDs, it may be acceptable, but it has to be very regular. But I would personally avoid any NSAIDs. And for ARBs and ACE inhibitors, even regular doses are not desirable and not recommended, because even with the regular doses, lithium toxicity and other side effects can occur. So drug interactions, it's so important to be mindful. Other thing is thiazide diuretics. So thiazide diuretics and to some extent loop diuretics, they can cause lithium toxicity. So the diuretics which will be entirely safe in lithium, it will be mainly the potassium sparing diuretics, and to some extent loop diuretics may also be helpful, but thiazide diuretics are kind of a big no-no and an absolute contraindication, while the loop diuretics are a relative contraindication. So beware of these drug interactions, and I think I have covered everything, and the other side effects, sometimes polyuria, mild tremor, so just to be mindful. And if they are not in a toxic range, just patient starts living with it, and some of the side effects may wear off after a few weeks. The next question are, what are the pros and cons of sustained and instant release formulation? So as far as it's lithium usually comes in a kind of sustained release formulation anyway. But even if it doesn't, it's a long acting thing. So lithium carbonate, for example, I am into the medicinal forms in the B and F, and it says lithium carbonate 250 milligrams tablets. So and then there is one from the modified release. So both are the same, but the main thing is not that you are giving sustained release tablet or you are giving the like the immediate release. The main thing is that you keep giving the same thing. I generally prefer the modified release, but you keep giving the same thing because of its bioavailability. And if you are changing from one preparation to the other preparation, then you have to take precautions, and it should be a long-term change. So you can't switch from one brand to another in case of lithium, and in case of mood stabilizers, the anti-epileptic mood stabilizers, and especially if they are being used for epilepsy, don't switch on and off again and again, because epilepsy will relapse. And then with lithium, bioavailability is so important, so don't just switch from one preparation to another. If someone is on Pridal or lithium from Essential Pharma or whatever, keep it on those. And Camcolit used to come. I think Camcolit is now almost discontinued, but if somebody is on Camcolit or Neurolith, for example, in Pakistan, Neurolith comes, so keep on the same preparation. Neurolith is an excellent preparation, so just whatever they are on, just continue that. And similarly, quetiapine, generally, what I do is I involve the patient in these decisions. So I tell them that this is the like, let's say, quetiapine XL or quetiapine immediate release preparation. I would ask the patient, I would put the ball in patient's court. What do you want? Do you want the action to be present throughout 24 hours, or do you want more medication during the night and you want to be fresh in the morning? So I would ask the patient what they prefer and what time do they want any morning dose. If they are wanting any morning dose, then yes, you can consider a long acting at night and nothing in the morning, and then that will give you about 24-hour cover. So there are pros and cons. Most of my quetiapine patients, they are on BD regime, so and because they are being used for emotional disturbance, so that's why BD regime is better. But once it comes to the bipolar mood stabilization, I may prefer the Nocte modified release regime. So these are all the questions and their answers. I would also try to put it on YouTube for you. Thank you, Muneeb. Allah Hafiz.